Hello, and welcome to today's Tune Into Safe Healthcare webinar, Making Dialysis Safer for Patients, Bloodstream Infections, Wall Boxes, and Lessons Learned, hosted by the Centers for Disease Control and Prevention. My name is Lauren Moshe, and I am the coordinator for the Making Dialysis Safer for Patients Coalition. This webinar is part of a series of infection control-related webinars that CDC hosts, along with a variety of external partners and experts. We thank you for tuning in today. Before we get started, we have the following disclaimers to show. And the following disclosures. This webinar is accredited for physicians, nurses, pharmacists, dialysis technicians, certified health educators, public health professionals, and other health professionals. The next two slides show the accreditation statements for the continuing education. Instructions for obtaining continuing education will be provided at the end of the webinar. I would now like to introduce our speakers for today. Our first speaker is Dr. Shannon Novosad. Shannon is a medical officer with the Dialysis Safety Team in the Division of Healthcare Quality Promotion, DHQP, at the Centers for Disease Control and Prevention. Dr. Novosad received her medical degree from the University of Alabama at Birmingham. In 2015, Dr. Novosad came to CDC as an Epidemic Intelligence Service Officer assigned to DHQP, where she investigated outbreaks in healthcare settings. Her areas of concentration include prevention of central line-associated bloodstream infections and increasing the safety of patients on dialysis. Our next speaker today is Kristen Van Allen. Kristen is an infection preventionist with DaVita, who has worked in dialysis for over 13 years and has served as an in-center hemodialysis nurse, a clinical coordinator, and a facility administrator before taking on the role of infection preventionist. Kristen received a BSN from Regis University in Denver, Colorado, and an MSN from Western Governors University. She has a certification in infection control and a certification in nephrology nursing. Our last speaker today is Robert Allen Whitney IV. Robert is the Senior Manager of Biomedical Services with DaVita. He has a degree in electronic engineering and currently oversees DaVita Technical Support and Quality Managers. He has 30 years of experience in the biomedical industry and has been with DaVita for 8 years. I would now like to turn it over to Dr. Novosad to begin today's presentation.
Thank you. As you all can tell by the title of this webinar, we're going to be discussing bloodstream infections, wall boxes, and lessons learned. I'm going to spend the bulk of my time discussing an outbreak investigation of gram-negative bloodstream infections associated with wall boxes. But first, I'm going to discuss briefly the risks of water and plumbing in the healthcare setting, as this is critical to understanding the risks associated with wall boxes. And then I will touch on some infection prevention and control measures we developed using the lessons learned from this outbreak investigation. As a disclaimer, I will often use the word water when I am referring not only to water, but plumbing systems as a whole, meaning every use of water in the healthcare setting, from the tap to the drains, and even toilets where waste is emptied. These wet environments support microbial growth and serve as a source of pathogens and potentially healthcare-associated infections, or HAIs. Tap water meets stringent safety standards in the United States, but it's not sterile. Certain numbers and types of bacteria and other microbes may be present when water leaves the tap. For typical household uses such as washing, bathing, drinking, and food preparation, these microbes rarely pose a serious health risk. In contrast, in healthcare settings, the way we use water are more varied, and patients might be more vulnerable to infection. There are particular microorganisms or pathogens that are associated with water. Many or most of these pathogens are environmental organisms and found in water under normal circumstances, and not necessarily contaminants of water, although we frequently do refer to them as contaminants. These include a wide variety of pathogens from gram-negative bacilli, gram-positive bacilli, fungi, and free-living amoeba. And as already mentioned, the risk to the general population is low, though some special populations do exist, such as persons with cystic fibrosis, immune suppression, and pre-existing lung damage. Listed here on this slide are just a few of the water-associated pathogens that we see, including Legionella, the group of pathogens known as non-fermenters, which includes Pseudomonas aeruginosa and Burkholderia cepacia complex, Another group of pathogens, the non-fecal coliforms. These include Enterobacter, Klebsiella, and Serratia species, the non-tuberculous mycobacteria, and even fungi such as Aspergillus. Certain conditions within healthcare plumbing systems can even encourage microbial growth, meaning those opportunistic or environmental pathogens can multiply. Some system issues that can lead to pathogen multiplication include disruptions, inner pressure drops, loss of disinfection residuals, renovations, and the age and design of the system. Altogether, this can lead to dangerously high levels of potential pathogens. Pathogens that are present in water and plumbing have certain properties that make them hard to eradicate, including thermal tolerance, survival and growth under low oxygen conditions, and slow growth. These microorganisms also have a tendency to associate with and stick to surfaces. These adherent organisms can initiate and develop biofilms. A biofilm is an assemblage of microbial cells that become associated with or stick to a surface and then are enclosed within a complex matrix of extracellular polymers, mostly polysaccharides and proteins, that facilitate adhesion and provide a structural matrix. The solid-liquid interface between a surface and an aqueous medium, such as water or blood, provide an ideal environment for the attachment and growth of microorganisms. These biofilms are difficult to remove and may become irreversibly associated with a surface, such as a pipe or sink drain. It is inevitable that biofilms will form in most water systems. In the healthcare facility environment, biofilms may be found in the potable water supply piping, hot water tanks, air conditioning cooling towers, or in sinks, sink traps, aerators, or shower heads. Biofilms, especially in water systems, are not present as a continuous slime or film, but are more often scanty and heterogeneous in nature. The slide here shows a picture of the many ways that water can be used in the healthcare setting and illustrates there are many possible avenues for patient exposure to water. And for water can potentially lead to infections in patients. From the patient rooms with sinks and showers to operating rooms, dialysis units, wastewater facilities, and even lobbies where fountains or other decorative water features may be present, food services where water is used to prepare food, and the water treatment facility where the water is treated prior to circulating through the facility. And there are other settings that are not shown in the schematic, such as the pharmacy, where water can be introduced during the preparation of medications. Given all of this, it's not surprising that a number of outbreaks associated with water exposure have occurred in the healthcare setting. This slide shows just a sample with different exposures across multiple settings, including an outbreak of non-tuberculous mycobacteria or M. abscessus infections in pediatric dental patients associated with water exposure during procedures, another outbreak of NTM linked to humidifiers used during LASIK surgery in an outpatient clinic, and an outbreak of Pseudomonas associated with tap water in a neonatal intensive care unit. And similarly, in the dialysis setting, numerous outbreaks have been associated with water exposure, including an outbreak of Serratia associated with contamination of injectable medications, and one of many outbreaks associated with introduction of pathogens during reprocessing of hemodialyzers. Now I'll move to discussing the outbreak associated with wall boxes. Gram-negative bacteria are an uncommon cause of bloodstream infections in hemodialysis patients, as a majority of bloodstream infections are due to gram-positive organisms such as Staphylococcus. However, as previously mentioned, gram-negative BSIs have been linked to water sources in this setting, including preparation of medications close to sinks, introduction of water into reused dialyzers and incomplete disinfection of these dialyzers. Here on this slide, we see a dialysis station, which, as you all know, consists of many parts in close proximity. The arrow here shows one particular part of the dialysis station that we're talking about today, and this is the wall box. They are sources of water located in the station that have not previously been investigated as a source of gram-negative bloodstream infections. Wall boxes contain several connections that allow the dialysis machine to hook up to the water supply, as well as the acid and bicarbonate concentrates, as indicated here by the blue arrows. In addition, waste lines from the dialysis machine can connect and the waste can empty into the sanitary or municipal sewer system. CDC first became aware of this outbreak via an algorithm used to detect clusters of infections or outbreaks using data reported to the National Healthcare Safety Network, or NHSN, which is the largest healthcare-associated infection surveillance system in the U.S. This algorithm detected a cluster of gram-negative bloodstream infections at a single facility. CDC subsequently consulted with the state health department, where we found that 3 outpatient hemodialysis facilities, which we'll refer to as A, B, and C, each had large clusters of gram-negative bloodstream infections. A number of different gram-negative organisms were identified, including Serratia marcescens, Pseudomonas aeruginosa, and Enterobacter cloacae. A common point source, such as a contaminated product, was considered possible as all 3 facilities were owned by the same company and located in close geographic proximity. In October 2016, an on-site investigation was initiated. A variety of activities occurred, including a case control investigation, infection control assessments using standardized CDC tools that included audits of CVC care, injection medication handling, and hand hygiene. Environmental samples were collected and included swabs from multiple areas such as sinks, dialysis stations, including prime buckets, counters adjacent to medication preparation areas, and in pods where infections occurred, and wall boxes. In addition, water samples were collected from sinks in the patient care areas and reverse osmosis tanks. Pulse field gel electrophoresis, or PFGE, as well as whole genome sequencing were used to compare patient and environmental isolates when organisms were the same. A case was at least 1 gram-negative organism isolated from blood during July 1st, 2015 to November 30th, 2016 in a hemodialysis patient treated at facility A, B, or C. Case finding included review of facility electronic medical records, as well as queries of infection control staff at area hospitals. A case control investigation was conducted at facilities A and B, which were the centers with the greatest number of cases. Each case was matched to one control on facility and symptom onset date, and controls were excluded if in the 2 weeks prior they had evidence of infection. In addition, we completed facility infection control assessments using some of the standardized tools we've developed at CDC and included observations of central venous catheter care, injection medication handling, and hand hygiene. For patient isolates, identification and confirmation were performed using MALDI-TOF. For environmental isolates, including the swabs and water samples, they were processed in methods to isolate the target organisms, specifically the gram-negative organisms of interest, were used. And as mentioned previously, PFGE and whole genome sequencing were used to compare samples when the same organism was present. Shown here is the epidemic curve color-coded by facility. As you can see, cases started as early as spring of 2015. The y-axis shows the number of cases, while the x-axis indicates the date of positive blood culture. Each facility is shown in a different color, A in blue, B in orange, and C in gray. The box indicates the time of our investigation period, which was referenced earlier when I introduced the case definition. The arrow shows when the on-site investigation started. Visually, this shows that this was a prolonged outbreak spanning over a year with a large number of infections at each facility. Shown on this slide and the next couple of slides are characteristics of the 58 cases. These include a large number of gram-negative organisms isolated, the most common being the Serratia marcescens, Pseudomonas aeruginosa, and Enterobacter cloacae. 28% had greater than 1 gram-negative organism isolated. And when looking at outcomes, over 80% were hospitalized. The median length of hospitalization was 8 days, and 1 patient died within 2 weeks of positive blood culture. 58 cases occurred in 51 patients, so you'll see the denominator is only 51 on this slide. Shown here is the distribution of cases across facilities. So for A, B, and C, you can see again that the majority of cases occurred in facility A and B. And then moving on to dialysis treatment characteristics. The majority of cases dialyzed after the first shift, so meaning the second and third shift. 55% dialyzed Tuesday, Thursday, and Saturday, while around 41% dialyzed Monday, Wednesday, Friday. Only 1 underwent nocturnal dialysis. And greater than 85% had a central venous catheter for dialysis access, while more than 50% had greater than 3 staff involved in a single treatment session. Moving on to the results of the case control investigation. When looking at time on hemodialysis, more time on hemodialysis was protective, so more than 26 months had a lower odds of infection. And then looking at some specific dialysis treatment risks in the case control investigation. So dialyzing after first shift was associated with greater odds of infection. And having a central venous catheter was again associated with higher odds of infection. And then finally, more staff in each dialysis session. So having greater than 3 staff in a single session was associated with higher odds of infection. The infection control assessments, we observed multiple missed opportunities for hand hygiene, and we did observe that supplies and medication preparation areas were found to be adjacent to sinks. As seen on the picture here, you can see circled in the blue, very close to a sink without a splash guard in place. So again, highlighting the different avenues that water could be introduced in this investigation. We observed multiple times of inadequate aseptic technique during CVC care and manipulation of CVCs and other vascular access sites after staff had touched the wall boxes. Other practices we looked at for potential introduction of water include dialyzer reuse. So shown again here on the slide is the epidemic curve, but we added in arrows that show when dialyzer reuse stopped at each facility. So you can see that all the facilities had been reprocessing their dialyzers, but facility A and C stopped right as the outbreak began, and facility B stopped the following spring. We had numerous opportunities to observe the wall boxes, where we saw that water and other liquid often drained into the basin and frequently pooled there, as indicated by the arrows. There is actually some water here in these pictures. It's just difficult to see against the white plastic of the wall box. And then here on this slide, again, pictures that we took during the investigation, but the holes there where the arrows are pointing, those are the air gaps. And you would frequently see wastewater would bubble up through these holes, and again, contributed to the basins being frequently wet with visible pools of water or other liquids. Interviews with staff revealed significant issues with wall boxes that were first noticed around early 2016, which included foul odors and clogged drains. There were further reports that staff were not consistently performing hand hygiene after touching connections at the wall boxes. So for example, you can see in the top image, the waistline has been unhooked from the connection and there's visible sediment clogging the line. And in the bottom, there's foam filling the basin of the wall box. We collected 43 samples from facilities A, B, and C. Numerous gram-negative organisms were recovered from the environment, as illustrated in the table here, including the 3 most common outbreak pathogens, Serratia, Pseudomonas, and Enterobacter. Every wall box sampled at all 3 facilities had at least one of these 3 organisms, but in contrast, water samples, other surfaces, and sinks rarely contained these 3 most common organisms. We found no patient isolates were related across facilities by PFGE, and because of these results, a single source among facilities was thought to be less likely. However, a patient isolate was found to be related to a wall box isolate within a single facility, as illustrated by the PFGE shown on this slide. Whole genome sequencing confirmed no related patient isolates across facilities, but again confirmed there was related isolates within facilities, and again confirmed the PFGE findings of the related wall box and patient isolates within the single facility, Facility C. In addition, in another facility, a patient isolate was found to be related to a wall box isolate, further strengthening the association between wall boxes and patient infections. Our lab findings were interpreted in conjunction with our epidemiologic investigation, infection control observations, and staff interviews. Many potential water sources were identified but did not contain the target organisms. However, targeted environmental sampling and comparison of isolates using PFGE and whole genome sequencing helped to reveal an indistinguishable patient and wallbox isolate in the same facility and confirm a previously unrecognized source of infections. Central venous catheters and increased staff involved with care were identified as risk factors and supportive of general infection control breaches, while dialyzing later in the day potentially indicated environmental contamination contributing to the infections, but by themselves these risk factors were unable to point to the source of infection. Infection control assessments showed wall boxes could be a potential source of water, that they were malfunctioning, and also provided mechanisms such as poor hand hygiene by which organisms can move from the wall box to the patient during central venous catheter care. The facilities had already started implementing control measures. We recommended that the affected facilities, to decrease the risk of infections from the wall boxes, they needed to continue to focus on two areas. One, improve infection control practices, specifically central venous catheter care and hand hygiene, and to continue a routine wall box disinfection and declogging regimen. So why is this important? There are greater than 6,500 outpatient hemodialysis facilities, and wall boxes are present in every facility. We thought we needed to explore design aspects and disinfection protocols to decrease the contamination in the dialysis station wall boxes and raise awareness among centers of this newly recognized source of infections. So this led us to develop a list of infection control and prevention issues that we thought would apply widely to wall boxes from facilities across the country. I'm going to first list out the issues, and they're here on this slide, that we typically see associated with wall boxes, and then we'll dive a bit deeper into each one of these issues. First is that staff may lack awareness of infectious risks associated with wall boxes and necessary infection prevention and control measures. 2, wall boxes are part of the immediate patient care environment and are considered contaminated or dirty. 3, wall boxes contain drains that are predisposed to the development of biofilms. 4, wall box drains may become clogged, and splashing and foaming at the wall box may occur. And finally, biofilms in wall box drains may contain opportunistic pathogens that can cause HAIs, or healthcare-associated infections. So again, to dive a little bit deeper into number 1, which is that staff may lack awareness of infectious risk associated with wall boxes and necessary infection prevention and control measures. So first, after hearing the presentation today, if you're not already doing so, I hope you'll all go back to your facilities and educate staff on the risks associated with wall boxes and the practices to prevent wall box-related infections, which we're going to discuss. One of the most important things you can do is perform hand hygiene after coming into contact with a wall box or any of its components. This should be regularly reinforced and assessed to make sure compliance remains high. Number 2, that wall boxes are part of the immediate care environment and are considered contaminated or dirty. There are a lot of steps and strategies associated with this issue, so they've broken down across a few slides. But usually, as we always do, we'll start with the policy. Each facility should develop policies about the specific frequency and methods for wall box surface disinfection. And then in regards to the actual cleaning of the wall box should be disinfected at least daily. Ideally, at the end of the day, after all patients have dialyzed, cleaning and disinfection may be needed more frequently. And cleaning and disinfection of the wall box should be performed after the patient has left the station and not during other patient care activities. I'm going to go back to the slide before it. Actually, I forgot the 2 things there. But be sure, as usual, to follow the manufacturer's label instructions for proper dilution, preparation, contact time, and use. And suggestions for disinfectant selection are described within CDC's notes for clinical managers, which you guys have probably seen before. And then finally, I mentioned there's a lot for number 2. You should use an Environmental Protection Agency or EPA registered disinfectant, and it should be applied to all surfaces of the wall box and any attached hoses. Ensure high-touch surfaces, such as the connections, are disinfected. Wipes or other supplies used to disinfect the wall box should be discarded after use, and not used to disinfect other surfaces in the station. So for example, a wipe used on the wall box shouldn't next be used on the chair. And then finally, more than one disinfectant wipe or application may be needed to ensure that all wall box surfaces are visibly wet. For issue number 3, wall boxes contain drains that are predisposed to the development of biofilms. To help with this issue, your facility should consider having practices in place that decrease the rate of biofilm formation and use these as preventative measures on a routine schedule for drains and traps. Examples include using drain cleaners, drain gels, or enzymatic cleaners. And as stated before, chemicals should not be mixed and follow the product instructions for use. Issue number 4, wall box drains may become clogged and splashing and foaming may occur. There are a few things that can be done to fix or help decrease this issue, including utilizing the services of a qualified plumber to help remove clogs. If the clogs persist or start happening more frequently, you may need to modify how often that plumber comes to work on the drains. And a final strategy could be to use a different type of wall box. There are many different types, and an ideal wall box would separate dirty, the waistline and drain from the clean, the acid bicarbonate and RO water supply connections, and relocate or reconfigure the air gap if foaming or splashing is persistent. And then finally, issue number 5, biofilms in the wall box drains may contain opportunistic pathogens that can cause HAIs. So for this, conducting routine surveillance, for example, monthly for HAIs, including bloodstream infections, and regularly reviewing the results can give you a hint that there may be problems occurring at your wall boxes. Blood cultures positive for gram-negative organisms commonly found in water-related biofilms should prompt investigation into possible reservoirs in the patient environment, including wall boxes. And you can always contact local or state public health authorities to help investigate potential wall box-related infections and clusters. Further, we identified some design features and other wall box attributes that may contribute to the likelihood that you'll notice issues with your wall boxes, including smells, clogging, and foaming, or that wall boxes will lead to patient infections through contamination of healthcare personnel hands or the environment. Robert Whitney will discuss some of these features in more detail. These include separation of clean and dirty, meaning dirty, the waistline and drain, from clean, again, the acid, bicarbonate, and RO water supply connection areas. Splash at your wall box. For example, we saw in some of our visits that water or other liquids would actually splash from the wall box out to some of the other equipment in the station. You could see evidence of this as it dried. Depending on how your P-trap is configured, it could mean that there's a larger risk of the contamination from organisms. And again, the air gaps similar to the P-traps can contribute to how likely your wall box is to have some of the problems with the foaming and splashing and such. So some take-home messages. Wall boxes are a source of pathogens that can result in infection. Hand hygiene should be performed after coming in contact with the wall box or any of its components. Environmental surface disinfection procedures should include the wall boxes. They need to be regularly cleaned and disinfected, at least daily. And obvious wall box dysfunction should be addressed immediately, including splashing and foaming and clogged drains. On the CDC website, we have some of this information available, including kind of the list of infection prevention and control issues and suggested strategies, which you can see here. And we recently published a description of this outbreak in AJKD as well. And now I'll turn it over to Kristen.
All right, let me share my screen. Oh, there we go. Okay. Hi, everyone. My name is Kristen Van Allen, and I'm going to be talking to you guys about how we increased our infection prevention strategies in order to reduce the risk of wall box contamination. And then I'm going to turn it over to Robert Whitney to present the biomed portion. So once the outbreak had occurred, we were faced with the challenge of how to prevent it from happening again in order to keep our patients safe. We needed to take the knowledge gained from the investigation and determine what changes needed to be made and how to best make them. So not only did we need to make the changes, but we also needed to make them stick in over 2,500 in-center clinics. We also continued to evaluate the policies and process and make adjustments as necessary. So first I want to explain the infrastructure we have here at DaVita as it relates to infection prevention. So I work as an infection preventionist, or IP, and our department consists of 9 IPs who are all nurses, and we are all either certified in infection control or we are in the process of obtaining this certification. We each cover approximately 350 plus clinics, and we are responsible for educating the field on infection-related subjects, and we also do infection surveillance and assist facilities with responding to their infections. So after the outbreak, we developed a work group consisting of several infection preventionists in order to figure out how to best proceed. Not only did we know that we needed to make some policy changes in order to ensure patient safety, but we had to figure out how to respond to gram-negative infections as they occurred in order to detect any potential clusters before they resulted in an outbreak. So we came up with a plan that resulted in several changes, including 1, revisions to our existing infection control policy, 2, field education. We wanted our teammates to absorb the new learnings and understand the why behind the policy changes so they were more invested. 3, we developed tools for the field. These were to help spot problems early on and prevent BSIs or outbreaks from occurring again. And then 4, we also developed a response process and tools to respond to infections as they occurred. So let's start by reviewing the policy changes that we made. So first, to make immediate changes to teammate practices, we updated the existing infection control policy to be more clear around certain practices. We made the following changes. So we revised the station disinfection process to include disinfection of the wall box and the machine, drain, and water lines. We added a statement that spray bottles should not be used to clean the wall boxes. We added specific language to state to remove gloves, perform hand hygiene, and put on new gloves if necessary after working in the wall box. We addressed machine handling during transport to state that the drain and water lines should not be draped or placed in the prime bucket in order to avoid contamination from the lines or dripping water. And then we also added a statement to the infection control policy that teammates should report certain red flags to the biomed and FA that they see in the wall box, such as broken connectors or possible drain patency issues. So next, we worked on some education for the field. We didn't want to just make these drastic changes to the infection control policy and leave it at that. Sometimes new policy changes take a while to stick, and if people don't understand the why behind them, they may be less likely to comply. Therefore, we decided to develop a WebEx course that detailed the policy changes and the why behind the change. We sent this recording out to all of our infection managers that worked at the facility level, and we asked them to share the information with our teammates. We also sent it out to the managers of clinical services, who are the nursing specialists that work with our clinics, for them to review, and we distributed it to our biomed teammates. So we wanted to hit on several things in this education, and we included the following. Gram-negative pathogenicity. Why are we so concerned about gram-negative bacteria? We included the fact that they can be highly resistant to antibiotics. Why the CBC is a risk factor in our patients. The different methods of transmission, and the common reservoirs in the clinic that might harbor these types of bacteria. We also discussed cross-contamination, so how this can occur during our normal workflow in ways we might not have thought about in the past. We educated the team on red flags in our wall boxes, so what should we be looking for to spot problems early on? And Shannon covered a lot of those in her slides. And then we also discussed the environmental services or housekeeping as an important part of the equation. So then to take it a step further and be a little more proactive, we updated our infection control audits to assist with the adherence of these policy changes. We audit infection control practices in our facility monthly, and now the auditor is asked whether or not these policy changes are complied with. In addition, we also created a one-page tool that is designed to help the manager of clinical services, the biomed, or really whoever wants to use this tool, look at the environment and teammate practices for potential risk factors. This was so that we could take more of a proactive approach to ensure patient safety. Any teammate can use this tool and give feedback to the facility administrator in order to get problems resolved. So at this point, we've addressed policy, we've educated the team, and we created a prevention tool. However, as infection preventionists, we felt we needed to be proactive if we did see a gram-negative bloodstream infection occur in one of our facilities. So over a series of several months, the work group met weekly in order to develop a process that would allow us to respond to each event that occurred. So out of this work group came several tools, including a surveillance algorithm that assisted the infection preventionist with decision making, a standard communication template to make the process easier. This makes sure that the process is uniform and easy for the infection preventionist to execute. We developed a patient clinical summary form to get more details on each patient. We developed a facility-specific process audit to the modes of, a facility process audit that it was specific to the modes of transmission usually associated with these types of pathogens. And then we created a standard form to assist facilities with holding governing body meetings. In addition, this little visual at the bottom here is a standardized tracker that we created to assist the infection preventionists with keeping track of everything going on in their facilities, and that would allow us to detect clusters earlier. So, the process, first we start off with the identification of a gram-negative BSI, and we do look at both internal and external blood cultures, anything that's reportable in NHSN. So once the infection preventionist identifies a gram-negative bloodstream infection, we use the algorithm to determine the next step in regards to whether to jump to the full process or just to request some clinical information first. So we look at a facility surveillance history to determine if it's the first gram-negative BSI in 90 days. And if there is, we just send the clinical summary. However, if the facility has a history of more than one gram-negative BSI, we're going to escalate it a little sooner. So if this is the first gram-negative, we send the email to the facility requesting that they complete the clinical summary on the patient. So this clinical summary just has some basic questions that look for a source for the BSI. So once this form is returned, the infection preventionist reviews it and goes back to the process algorithm developed to determine the next step. If a source has been identified and it is determined that the infection is from a wound or UTI or some other source not related to transmission in the facility, we do ask for supporting documentation and we close the case out. However, if the source is undetermined, we send the facility process audit, which asks questions regarding teammate practices and the environment. So examples of things that are on the audit include wall box cleaning, prime bucket cleaning, and the status of the drains. So when the facility process audit is returned, we review it and schedule a call to close the loop and assign action items to the facility. These action items might include holding an in-service with our teammates on station disinfection or reaching out to the biomed to resolve any drain issues that are present in the facility. They may include patient-specific actions such as patient education as well as facility-level actions. So the facility completes the actions that are assigned by the infection preventionist and a governing body is held, and it's documented in the quality assessment and performance improvement notes. The IP continues to keep eyes on the facility using the tracker to ensure that we're not seeing a cluster or a trend. So as this process has evolved, we do continue to update the tools and forms based on feedback from both the teammates in the field and from the infection preventionist. We are actually on version 25 of these tools. We've also taken learnings from this process and developed what we call homeroom lessons for staff education and competency. We were able to develop specific homeroom lessons around topics such as wall box cleaning, station disinfection, and CBC kitting, among others. This process has allowed us to identify areas in our policies and procedures that may need clarification or revision in regards to infection control, and we have also formed an infection preventionist work group that is specifically assigned to reviewing and updating these policies. In addition, we were able to identify gaps in our current infection control audit. We added a piece on housekeeping to ensure that these services were being performed appropriately by our vendors. And lastly, we have shared what we call case studies with other infection preventionists so that we can learn from each other. So it's difficult to quantify the impact of these changes alone because there are so many confounding factors. So I can't give exact statistics, but I can say that the facilities are letting me know when they have a gram-negative BSI now. They're actually filling out that form and sending it to me because they're so hyper aware of these. And our clinical services managers are bringing potential issues to our attention, and we're working very closely with Biomed to get these resolved as quickly as possible. So now I'm going to turn it over to Robert Whitney to address drain issues.
Thank you, Kristen, and hello, everyone. This is Robert Whitney. What I'm going to be covering today is addressing dialysis drain issues from a biomed standpoint. So what we've seen is issues in our facilities with clogs, foaming, odor, and drain flies. So to address these issues from a national team perspective, we put together an assessment to provide the frontline teammates with recommendations for what issue they're having. And what I'm going to share today is what that assessment looks like. So first thing we're going to look at is the drain slope. What we're looking for here is a 1/4 inch per square foot drain slope. So no process that we put in place is going to work if our drains are running uphill. So if we do see that scenario where our drains are uphill, we're going to ask the teammates at that point to work with the plumber to fix the issue. Next, we're going to look at foaming problems. What we typically see here is foam buildup over our drain pipes. And what we do to correct this is put 2 45-degree angle fittings to change the velocity of flow. So for an example, it's like pouring a Coke into a glass. If you pour it in the middle of the glass, it will foam up. But if you pour it on the side, it doesn't tend to foam as much. And we've been successful with implementing that. And again, we're going to ask the teammates to work with the plumber to get this action taken care of. The next thing we're going to look at is clogs. We want to make sure that our water boxes, floor drains are clear of any debris. Things that we typically find is dialyzer caps, trash, saline caps, and bloodline caps. So any debris in our drains can provide a place for protein buildup and cause a clog. So we want to ensure that any debris is removed from our drains before we move forward with the assessment. After our drains are free of debris, we want to ask our teammates if they have any kind of protein buildup. And what we're going to be looking at is chase boxes, floor drains, chase drain lines, machine drain lines. So all depending on where they're having the issues to what our recommendations may be at this point. Next slide, please. The next thing that I want to address is odors. We need to understand where the odors are coming from, whether it's from our chase boxes, from our floor drains, and then we can provide the proper recommendation to take care of the issue. Then we want to look at air gaps. We want to make sure we have sufficient air gaps, and what we're looking for here is 1 inch of air gap or what local plumbing codes are requiring. Next thing would be Studer vents. These are the vents in the drain lines themselves that allows proper drain flow, so they actually vent your drain lines. So it's important that these are operating correctly. What we've seen in the past is drain flies clogging up the vents and preventing them from opening correctly. And again, a plumber may be necessary to get these Studer vents replaced, but if we do see them being clogged, we want to get them replaced as well. The next thing is flies. If there's an infestation, we want them to contact an exterminator and set up treatments to remove the flies. And when they're treating, they need to think about and treating the entire facility, because if you treat one location, they will move to where you did not treat. Places like old break rooms, reuse rooms, or your any room that you haven't been in quite a while, they have a tendency to move to. And we want to make sure that our kitchens are also addressed. We don't want to leave them out in this practice. The next thing is machine drain hoses. We want to ensure that there is no buildup in our machine drain lines. If so, we do find them with buildup, we want to replace them or clean them, whichever option works the best. And we want to make sure that there's no restriction in our drain lines, like quick disconnects, because this can provide a place for buildup as well in these connections, and we want to make sure that our drain lines are free flowing. So that's some of the things that I wanted to cover from our assessment, and I want to thank you for your time on today's call.
Thank you, Robert. I want to thank all of our speakers today for their insight. We do have a few minutes to go over some questions that came in. So the first question I have is for Dr. Novosad. Of all the interventions mentioned in today's presentation, is there one you feel that is the most important takeaway, or the one thing we should be bringing back to our facility for training?
I think, obviously a lot of the things we talked about are of various importance, I think, depending on what exactly the wall boxes look like in a particular facility. But I think the one thing that can really apply universally is the recommendations surrounding hand hygiene. We didn't get into a lot of details during the presentation, but we did mention, that there were 2 different facilities where we found matching patient and wall box isolates. And in fact, in one of the facilities, we really didn't notice much wall box dysfunction in that particular facility. We did see the wetness that we talked about, but we weren't seeing the clogging or the foaming or any of the smells. But again, we're still seeing patient infections that we thought were related to the wall boxes. So I think hand hygiene is something that if universally practiced across all facilities, in particular, with some of the highlights after coming into contact with the wall boxes, that, patient infections that could be happening without over wall box dysfunction, could be prevented.
Great. And one other question for you, Dr. Novosad, is do we know the extent of how widespread this issue is of wall boxes causing infections in dialysis?
So no, that's a great question, but no, we really don't know how widespread this issue is. For example, in this investigation, we were able to find this association between wall boxes and these infections, but again, there was a really large number of infections across multiple facilities, and while we, can say that some of the infections were associated with wall boxes, we don't know that all of the infections were. So again, even in this case, we can't give an exact number, or an extent of the wall boxes. And we don't know if this is occurring at, a smaller level across, many facilities across the country, or how many of the gram-negative infections we see are associated with wall boxes. So again, it's something we suspect could be occurring, more widespread, but, based on the information we have now, we're not able to put an exact number on it.
Great, thank you. The next question I have is for Robert. Have you ever observed just one symptom of biofilm formation, such as an odor with no foaming or other visible issues, or do you typically see multiple issues appear together?
Well, I will say it is definitely a mix of issues out there. We have seen where it's been one issue, but most of the time what we're seeing is multiple drain issues. That's why I think it's so important to put in place a drain assessment so you can ensure that you're catching all the facilities issues that may be having.
Great. Thank you, Robert. And then we had one other question come in. You mentioned having to remove any debris from drain lines that may have fallen into the line, such as dialyzer caps or other items. What is the easiest way to remove these items, or how do you go through that process?
Well, I would ask the teammates to ensure that they're wearing proper PPE before reaching into the drain lines, but most of the time we put on proper PPE and reach in and just remove whatever debris there may be.
Great, thank you.
Yes, ma'am.
So, Kristen, I have a question for you that came in. How did the staff receive and react to the new education and training you put in place? Were they receptive, or was there some pushback initially?
No, everyone was actually really receptive to it. It's actually really interesting information, and I think it was kind of like, you know, a newly documented source, and we all just want to keep our patients safe, so they were happy to watch it and learn more about how it happened.
Great. And then you mentioned that you asked the staff not to drape the lines into the prime buckets. Can you expand more on what staff now do instead?
Sure. We actually have them put a glove over the end of the line to avoid the water dripping on the floor and, like I said, into the prime bucket. And then some facilities have actually worked with biomed to get hooks installed that can be easily cleaned and will stay on the machines, and they wrap up the drain lines on that. Or the other alternative, they can still drape them on the IV poles, but then we make sure that they're not dripping water, and they're certainly not dripping them in the prime bucket. So the gloves on the ends really help.
Great, thank you.
Mm-hmm.
So moving on, to obtain continuing education for today's presentation, you will need to visit the TCEO website at www.cdc.gov/getce. If not previously registered, you'll need to complete a short registration process. And then once logged in, you can utilize the Search Courses tab and type in the keyword WD2720-121019, or you can search by the title of the webinar. There is no code associated with this webinar, so you should be prompted to then complete the continuing education assessment, the evaluation and post-test, and you need to score at least 80% to receive the continuing education. There are no fees for this continuing education credit. So I want to thank everyone for joining today, and I hope you enjoy the rest of your day.